All right, hello everyone. So this is a re-recording of what we did last night because there were portions of the video that did not record. So I wanted to just make sure that I went over the most important parts and kind of re-explain some of the things we went over, as well as we can talk about some of the practice problems I had sent over, and we can kind of get through it. So one of the big things I want to talk about again is the topic of Myasthenia gravis, because it's an interesting kind of application of what we have learned so far about the parasympathomimetics, all the acetylcholinesterases, and kind of following along those lines. So without further ado, let's jump right into talking about Myasthenia gravis. So I hope I'm on the right screen. Let me double check real quick. Perfect. So if we remember, Myasthenia gravis is an autoimmune condition in which the acetylcholine receptors on the nicotinic receptors are destroyed. So during this autoimmune flare-up, what happens is that these receptors are destroyed by immunoglobulins produced by the body, and we no longer can create a signal as we go past it. So let's take a little diagram and see what's going on. So in a normal cell, or in a normal kind of condition, we have our presynaptic nerve, and then we also have our postsynaptic nerve, which I'm going to show like this. And on the postsynaptic nerve, we're going to have the acetylcholine receptor. And we know that in a normal cell, the action potential will come down, which will cause voltage-gated calcium ion channels to open, which causes the influx of calcium, which moves the vesicles towards the membrane. The snaps and vamps help the vesicle fuse to the membrane wall, and that releases its products, which in this case is acetylcholine, which then bind to our acetylcholine receptors. And that's what these red dots are. These are acetylcholine. And by doing this, we're going to be transmitting that nerve signal from one nerve to the other. What happens in someone with myasthenia gravis, what's happening is that they lack these postsynaptic acetylcholine receptors, that for whatever reason, their immune system has decided that these receptors are foreign and starts to create immunoglobulins against them and destroy them. And so what's going to happen is that we're not going to have no signal transduction. We're going to have a weakened response, right? Because, well, oh, maybe all of, maybe on one nerve, all the receptors are gone, but for the majority, they're still going to have some somewhere. But overall, what this is going to lead to is it's going to lead to a muscle weakness. Right? And we know that as we talked about in pathology last year, that when multiple nerves are firing on the same postganglionic cell, then we have a stronger response. Same thing that if you open more of these nicotinic receptors, if you stimulate them more, then you're going to be causing a greater response on the muscle. And so, or on the, on the muscarinic or the nicotinic receptor where it may be. No, I believe for myasthenia gravis, we're talking about the nicotinic receptors at the neuromuscular junction. And that's what causes this muscle weakness, is that you have less acetylcholine being able to bind, which means a smaller response. So when these people are one of the biggest kind of hallmark signs of myasthenia gravis is this muscle weakness. And it's due to the lack of the nicotinic receptors. Now, there is another condition called cholinergic crisis. And cholinergic crisis can come about in a couple of different ways, but the way that we're going to be talking about it is you have someone with a normal postganglionic cell, the normal amount of receptors, and they're producing the acetylcholine that we expect. And this is on a nicotinic or a muscarinic receptor, because as we know, that acetylcholine is the neurotransmitter for the nicotinic and the muscarinic receptors. Except in cholinergic crisis, one of the biggest ways is that we have increased acetylcholinesterase inhibitor. So normally acetylcholinesterase binds to our acetylcholine and breaks it down into its components, which terminates this nerve response. And this is pretty quick, right? We don't want our muscles to be constantly stimulated because this means that they can't repolarize, right? They're going to be constantly stimulated. And so in cholinergic crisis, we're going to see muscle weakness again. And the reason is because we have so much acetylcholine binding to our cholinergic receptors that they're unable to basically turn off. And that means they're constantly stimulated, which means that you have very bad control over your muscle movements. And so you're not able to fully complete a nice coordinated muscle movement. So you have that ataxia, you have a muscle weakness from that overstimulation. And that can be caused by the toxicity by taking too much acetylcholinesterase inhibitor. If you block the inhibitor, then you increase the amount of acetylcholine, which means more nerve stimulation. Now, we're not talking about someone who's taking their acetylcholinesterase inhibitor as prescribed. We're talking about someone who is taking maybe too much of it. Maybe it's an elderly person and they mixed up the dosing or the frequency and they took 2 pills when they meant to take 1. Maybe they took 4. Maybe they're trying to commit suicide via these medications by taking way too much. But this is what we would find. Another very, very common way that we see this cholinergic crisis is actually from farming. And it's because there are molecules in farming called organophosphates. And organophosphates also inhibit acetylcholinesterase. Now, these organophosphates are part of your regular fertilizers. So if you were over in Illinois or Iowa, somewhere where farming is really, really big, or Kansas, you would find farmers coming in periodically with cholinergic crisis because they had inhaled or ingested these organophosphates. Now, what's important to note is that the symptoms of cholinergic crisis and myasthenic crisis are very, very similar. And this myasthenic crisis, this destruction of the cholinergic receptors, comes when there's stress on the immune system. And that causes an increase in the immune system's response, which then would lead to the destruction of more receptors. And so what we'll find is that someone will go through myasthenic crisis. And myasthenic crisis and cholinergic crisis can have similar symptoms. Hallmark of that is that muscle weakness. But we treat myasthenic crisis and cholinergic crisis completely different. We treat a myasthenic crisis, for a myasthenic crisis, if we're talking about a lack of receptors, then by increasing acetylcholine, we're going to increase the number of molecules that can bind to what little receptors we have. And so we're going to be increasing the percentage of bound cholinergic receptors. And how are we going to increase this acetylcholine? Well, we're going to administer acetylcholinesterase inhibitor. Sorry, we're going to administer the acetylcholinesterase inhibitor. Well, isn't this going to cause cholinergic crisis? No, because what we're trying to do is we're trying to raise this amount because it's dangerously low, right? That there's not enough spots for stimulation. So we're going to increase the percentage, the chance that at any given moment, those sites are stimulated. So to treat myasthenic crisis, we need acetylcholinesterase inhibitor. But to treat cholinergic crisis, the issue is too high of acetylcholine. So we need to decrease the response of acetylcholine. And what this is going to do is it's going to lower the percentage of bound receptors. And so we have really two ways of doing this. The first way is that we can administer a muscarinic antagonist. Or what we can do is we can administer a drug called pralidoxime. And let me make sure. And pralidoxime is an acetylcholinesterase reactivator. Specifically, it works on those organophosphates. So it helps remove the organophosphates from the acetylcholinesterase, so that way we can reactivate the enzyme so it does its job. So essentially, our two ways of doing it is with the muscarinic antagonist and try to block some of these receptors, or we increase the action of that acetylcholinesterase so we can decrease the concentration of acetylcholine. So we have two ways of managing cholinergic crisis. But what you can see is that even though that the overall, what we can see in the patient is similar, the muscle weakness, we can see that these are almost opposites of each other. And how we would treat one is completely opposite of how we would treat the other. So what we do is we administer a test. And it's called the Tensilon test. And Tensilon is the brand name of a drug called edrophonium. Now, if you remember from your slides, you know that edrophonium is an acetylcholinesterase inhibitor. But wait, what is that going to do? Well, what we do is we administer a very small amount of Tensilon, the edrophonium. And if the patient improves, then we know they're in a myasthenic crisis. So if we start to see, better muscle movements, However, if we administer the edrophonium and we start to see a increase in adverse effects similar to cholinergic crisis, which remember, we're talking about overstimulation of the nicotinic and the muscarinic receptors. So what are we seeing in people in cholinergic crisis? Well, we're seeing things like, all of our muscarinic effects. We're seeing over-salivation. We're seeing lots of secretions, so sweating, GI secretions. We're seeing lots of GI motility, so diarrhea. We're seeing the inability to hold in the urine because of the contraction of the detrusor muscle. So all these things, as well as our muscle weakness from the overstimulation of the nicotinic receptors on the neuromuscular junction. And so if we administer edrophonium, which is an acetylcholinesterase inhibitor, then we're essentially increasing more acetylcholine, which is then going to make this problem worse. But edrophonium is a short-acting drug, so we're not going to get a long-term effect. We're going to be able to see the patient have a worse response. We're going to say, ooh, okay, they're in cholinergic crisis, so let's give them a muscarinic antagonist. Or, oh, they were just farming for 6 hours and they were using fertilizer, let's give them pralidoxine. And so that's the big difference between these two big concepts about myasthenia gravis and cholinergic crisis. So that was something that I wanted to make sure that we went over again, because it is a kind of an interesting point as we go through. Now, what I want you to be aware of is that next week we're going to be going over, we talked about all these drugs that affect the muscarinic receptors, the parasympathomimetics and the lytics. Next week, we're going to be talking about the nicotinic receptors. So this week was all muscarinic, next week is nicotinic. Then we're going to be talking about those adrenergic receptors as we were. And if you're wondering what I'm talking about, I can show you here, is that first we talked about the muscarinic drugs, which affect this parasympathetic pathway. Next, we're going to talk about the nicotinic, which is going to be here. And then as well, some parasympathetic input. And then finally, we'll talk about adrenergic and kind of this big effect of the norepinephrine, epinephrine pathways. Cool. Now, I had sent out a practice set to talk about some of the drugs that we went over on Monday. And I just wanted to talk through the answers again, once because the recording didn't work, just so that way everybody's on the same page and we completely understand what's going on. Sorry, give me 1 second. There we go. Now I have my mouse. So question 1, the enzyme that's inhibited by physostigmine is what? Well, if we remember what physostigmine is, we can go to that section. And so expect on your pharmacology exams kind of these direct questions about what is the mechanism of action of these drugs. And so we know that the stigmines and the oniums are all drugs that inhibit cholinesterase, acetylcholinesterase. Now remember that too, that malathion is that irreversible inhibitor of the same enzyme. So we know here that the answer is acetylcholinesterase. Now, to practice, you should also be going over what the answers to these other enzymes are. So we can go back to our kind of look at the production of norepinephrine, and we can find that the enzyme that inhibits the tyrosine hydroxylase is that metyrosine drug, inhibits tyrosine hydroxylase. The drug that's the substrate or for dopamine beta hydroxylase is droxidopa. Nope. It would be dopamine is the substrate for that. And then the drug that's the substrate for aromatic amino acid decarboxylase, it's not even an answer here, would be the droxidopa. And finally, the VMAT inhibitor are all of the reserpine, the valbenazine, tetrabenazine, tetrabenazine. Cool. Which of the following drugs has the longest duration of action? Well, whenever you talk about duration of action, we're talking about reversibility of the drug. So automatically, long-acting drugs are going to be ones that are pretty irreversible. And so the only drug that's listed here that's irreversible is reserpine. All the following are responses to anticholinergic activity. Well, cholinergic activity is when we are mimicking the parasympathetic nervous system. So let's go there real quick. And so if we're going to be anticholinergic, then we're going to be anti all these different pieces. So I think I have a nice comparison chart. Yeah. So if we're going to be anti-parasympathetic, then we're going to have mydriasis. We're going to be, oops, this is the wrong chart. If we're going to be having anti-cholinergic activity, then we're going to be seeing decreased salivation. We're going to be seeing decreased GI excretions. We're going to be decreasing the amount of urine outflow because we're going to be relaxing the detrusor muscle around the bladder. So are we going to be seeing xerostomia? Yeah, totally. Xerostomia is dry mouth. Are we going to be seeing constipation? Totally, because we're going to be decreasing that GI motility. Are we going to be seeing urinary urgency? No, because we're going to be relaxing the detrusor muscle. And so we're not going to be seeing the inability to hold in urine. We're going to be able to hold in the urine a little bit better. Which locations are innervated by cholinergic synaptic sites? Well, we know that cholinergic synapses take place at the neuromuscular junction, so on that somatic, and we know that are they at autonomic effector sites innervated by postganglionic sympathetic fibers? Well, if we look at the sympathetic nervous system, what do we notice is that the presynaptically, so this is saying postganglionic. So preganglionic, it's acetylcholine. Postganglionic, it's norepinephrine. So is the sympathetic nervous system stimulated by, or does that have a cholinergic synaptic site? Not postganglionically. Postganglionically, it's norepinephrine or epinephrine. No, epinephrine is going through the bloodstream. So where are we going to find it? We're going to find it in some of the CNS synapses. Not all of them, but some of them. Which of the following is highly sensitive to acetylcholinesterase? Well, acetylcholinesterase only works on one molecule, as we know, and it's acetylcholine. Carbachol and bethanachol are muscarinic agonists, so they act upon the same receptor, but they're not broken down by acetylcholinesterase. They diffuse out of the synapse, which terminates the response. Which are the effect of the cardiac muscarinic M2 receptor mediated action? What does that mean? We're talking about cardiac, so what's the effect on the heart that's mediated by the M2 receptor? Well, we know that the M2 receptor is GI linked, which means that we're going to be decreasing CAMP, which means we're going to be lowering the stimulation. And so is it going to have increased phase 4 depolarization? No, because that's going to increase the response of the heart. Or are we going to have greater conduction velocity? No, because that's going to increase the heart rate. So we're going to see decreased atrial and ventricular contractility because we're going to be decreasing the overall effect on the heart. Which of the following is an indirect acting cholinomimetic? Well, we know that indirect acting means that we're acting not directly on the receptor. And so we just learned, again, that carbachol is a muscarinic agonist. So that means it acts on the muscarinic receptor directly. So it can't be carbachol. Can't be acetylcholine, because we know acetylcholine is the natural ligand, right? That's the one that's acting on the muscarinic receptor anyways. Atropine is an anti-muscarinic. So again, it's acting directly on the muscarinic receptor. It's just having the opposite effect. And so the answer here is that edrophonium, that is acetylcholinesterase. What's the consequence of administering neostigmine to the conjunctiva in the eye? Well, if we go back, we look at neostigmine. Neostigmine, as we know, is a cholinesterase inhibitor. And so what we expect is the contraction of the ciliary muscle, because we know that acetylcholine contracts muscles, right? It causes contraction. So it's not going to relax the pupillary sphincter muscle or the ciliary muscle. It's going to contract the ciliary muscle. So trick question. An 18-year-old man, SD, attempts suicide by drinking 2 small bottles of liquid pilocarpine eye drops, about 8 ml, followed by injecting 1 ml of the same substance subcutaneously. Shortly after, he began vomiting. He was found by a friend, taken to the emergency department. What would be a major effect of taking this medication? Well, if we go and we remember pilocarpine, pilocarpine is a muscarinic agonist. And so we know that muscarinic agonists increase rest and digest. So what are we going to find? We're going to find that we're going to have more salivation. We're going to have increased urination because of the contraction of the detrusors. And a big effect of muscarinic agonists is that we're going to have bronchoconstriction, not dilation. But we are going to be causing the heart to beat slower. And so that's going to cause a decrease in blood pressure. So if this person is ingesting a muscarinic agonist, what would we treat him with in order to reverse the effect of the muscarinic agonist? Would we give neostigmine? Well, that's an acetylcholinesterase inhibitor. So we know that an acetylcholinesterase only works on acetylcholine. So would we give an inhibitor to acetylcholine, an inhibitor to acetylcholinesterase? No, that's going to increase his adverse effects. Would we give Botox? Well, that would decrease acetylcholine, but it wouldn't stop the muscarinic agonists. Would we give valbenazine? Well, valbenazine is a VMAT inhibitor. So that's going to be affecting norepinephrine. So it's not even in the same place. And then finally, the antidote for muscarinic agonists is to give a muscarinic antagonist. So do we really care what these doses are? No, you'll learn them in therapeutics. But what we do care about is that it's atropine. So when someone's ingested too much muscarinic agonist, or they're in cholinergic crisis, we would give them a muscarinic antagonist. How would the systemic pilocarpine affect bowel sounds? Well, we know it's going to be increasing rest and digest. So we're going to be seeing more, we're going to be hearing more bowel sounds. We're going to be causing mydriasis in the eye. We're going to be constricting it. And then we're going to be causing urination. Which of the following are clinical uses of anticholinesterases? Or in other words, acetylcholinesterase inhibitors? Well, we know that we can give someone with myasthenia gravis, we know we can give them an acetylcholinesterase inhibitor. So it's definitely A. We know we can use acetylcholinesterase inhibitor to help with glaucoma. We know we can raise the parasympathetic tone in order to help with the paralytic ileus, which means the intestines are not moving. We have decreased GI motility, and we have decreased bladder contraction. So we can give acetylcholinesterase to help with that. And then could we give it for Sjogren's syndrome where we have that dry mouth? Totally. So it could be all of the above. A new drug is being developed and its effects are being studied. It's found to be an antagonist at nicotinic receptors of autonomic ganglion cells. Which of the following would be expected from the new drug? Well, what this is saying is that it's agonist at nicotinic receptors at autonomic ganglion cells. So we're not talking about somatic ganglia. So we're talking about here even at these nicotinic receptors. And so if it's an antagonist, we're going to be decreasing the amount of acetylcholine that's on the muscarinic receptor postganglionically. And so we're not going to be causing that muscle weakness, right? Because we're not going to be affecting the nicotinic receptors on the somatic ganglion cells. And so if we're going to be decreasing the amount of acetylcholine on muscarinic receptors, then we're going to be essentially acting like an anti-muscarinic. So we're going to see mydriasis. We're going to be seeing increased heart rate. We're going to be decreasing our bladder contraction. We're going to be decreasing GI motility. And so really the answers here are all three. Botox causes paralysis of muscles because it does what? Well, Botox, if we remember, affects the vamps and snaps, which prevents the release of acetylcholine. So we're not going to be increasing the production or the release of acetylcholine, and we're not blocking its breakdown by blocking acetylcholinesterase. We're just preventing it from being released. And then finally, a patient was found to have a clinical lack of aromatic amino acid decarboxylase when compared to the general population. Which of the following drugs would be prescribed in order to raise norepinephrine release? Well, we would want to give something that's going to integrate into that pathway that produces norepinephrine. And so would we give metyrosine, which blocks tyrosine hydroxylase? No, because that's going to decrease downstream norepinephrine. Would we give edrophonium? No, because that's going to increase acetylcholine. That has nothing to do with what we're trying to do. Same with the malathion and the tiotropium. These are not going to be acting on the same sites that we want. And so the answer is the droxidopa. And the reason is, even though this person has decreased aromatic amino acid decarboxylase, they still have some of them, which means that we need to make sure that the percentage of enzyme that's being used at any given time is as high as possible. And so we can do that by throwing more and more substrate at it. And so by throwing more substrate, we're going to be forcing the body essentially to have to use it up, which is going to cause more dopamine, which is going to cause more. Cool. All right, this was a re-recording. Hopefully this is helpful. If we have questions on Monday, please let me know. And we'll do nicotinic receptors. Thank you.